So good afternoon. I'm Russ Leftwich. I'm a senior clinical advisor for interoperability for InterSystems. And welcome. I'm very excited to be here doing this. It's always fun. This is actually the 27th time for this workshop. It's been obviously well received. And full disclosure, the acronym FHIR are in both my Twitter handle and my vanity license plate. So I'm not unprejudiced about the FHIR. But the idea today is to get the concept of FHIR. We're not going to code any apps at the end of this workshop, but to get everybody on the same page for what is FHIR really about. Some of you, I'm sure, are technical and already are very familiar with FHIR. Some of you are not, but are familiar with healthcare. Those are the two aspects of FHIR. It's the technology and it's the healthcare data model that underlies FHIR and how you get from there to semantic interoperability. So there'll be some details, but there will be a lot of things we won't talk about. And this is the afternoon's agenda, which you may have seen up earlier. Following a little introduction, I'm going to talk about the concept of FHIR at a very high level, and then a dive into the FHIR specification itself. And I used to tell people at this workshop 5 years ago when we were starting that a lot of the people would probably never look at it. Now I think I was wrong. Things have really changed over the past 5 years. I think a lot of people who are early in their career, even if they're not engineers, if they're not coding, I think a lot of people will still wind up becoming familiar with the FHIR specification as things go on. Then we're going to do a hands-on exercise. If you don't have the script for that, pick one up, and it is literally a step-by-step instruction. I will play a video of me going through the instructions. The purpose is really to sort of internalize what FHIR is as a data model and how data in FHIR looks very different from what we're accustomed to in documents and relational databases and so forth. And then I'm going to talk about FHIR servers and FHIR APIs at sort of a high level, but I think it's something that a lot of people have a little trouble understanding exactly at first, and you may not be one of those people, but I'll bet you know some of those people and may not realize how confused some people are about FHIR servers and APIs and so forth. And then we have a couple of our InterSystems customers who are going to show us in a very brief vignette what they have done with InterSystems technology and FHIR. So I want to start out talking about why we need FHIR, or why we needed it. I would trace it back to a report that the Institute of Medicine, now called the National Academy of Medicine, published in 2001 called Crossing the Quality Chasm. And the report was really about the healthcare system in the US and how there was a need to develop a strategy to improve the quality. One of the things they noted was that there was variation in practice across the US. Patients in some places got much better outcomes than patients with the same problem in another part of the US, which obviously suggests somebody knows how to do something better than somebody else does. The other thing that report noted was that there was a lot of data. Technology had advanced, and we had no effective way to exchange that data, to understand that data across different organizations. And the other thing was that they noted that humans just couldn't handle that much information in their head. They also suggested some changes to start working on, and this is the sort of call to action from that came out of that report. And the Institute of Medicine and other policy organizations had various work groups and meetings and conferences over the next 5-8 years talking about this, and suggested that the US needed some sort of organizing framework. We needed to set some quality goals. We needed to shift from organizational care to patient-centered care, and that was the call to action that came out of this report. So the other thing I wanted to talk about as we get started is, where does FHIR come from? And I don't know how many of you have been to an HL7 working group meeting or are familiar with the workings of HL7, but I wanted to make everyone aware because it's where FHIR comes from, if you will. HL7 is a nonprofit membership organization in the US, and then there are affiliates in some 40 other countries. In HL7, there are over 40 work groups, each with elected co-chairs. They meet 3 times a year in week-long meetings that include now a FHIR Connect-a-thon, and they develop the new specifications or updates to the specification, if you will, and then those updates are balloted in a consensus process in HL7 before they are published. Very important that this process requires that if anyone voting on a specification says, no, there's something wrong with this, they do have to say what's wrong, then the specification does not get published until the work group responsible resolves that person's no comment. So presumably it's a better product that comes out when it does get published. All of the HL7 standards, including FHIR, are open source and freely available. They're also accessible on the HL7 website. InterSystems has been a benefactor member of HL7 for over 20 years. The other thing I want to talk about is how FHIR is different from previous standards. So first, as you likely know, it's the technology of the World Wide Web. It's the first time that's really been applied to healthcare, and some people equate FHIR to the World Wide Web for healthcare. FHIR is a flexible data model by design that can be applied to a lot of different use cases. Not infinite number, but a very broad spectrum of use cases. And one of the important things I'm going to mention several times is that data model does not mean interoperability. It may mean more interoperability than you had without it, but that's not how we get to the goal of semantic interoperability alone. The other thing to know about the website where FHIR is that everything there is there in a machine-readable, downloadable format. So each of the releases of FHIR that have been published are there. And the other thing, the next edition of FHIR that's being worked on is also there as what's referred to as the current build. So people interchange requests on that current build, and they get implemented within a day or two by a few people who have editorial permission on that current build, and then at some point that current build gets balloted to be the next release of FHIR. So that's how it works. That's how it's very different from the previous standards that HL7 published, and there are over 300 of them. Those standards were published as documents that someone had to read and interpret, and although there were some tools, there was nothing like the machine readability and shareability of the FHIR standard. So it's all a paradigm shift for standards development, the way that FHIR is developed. This double diagram depicts where we were, or where we are maybe, on the left with point-to-point connections. I've estimated there are billions of them. There may be more. And a lot of people, when they hear about FHIR, think, well, it's going to replace all this. It's not in the foreseeable future. HL7 version 2 will survive the apocalypse. I'm convinced of it. We'll have V2 and cockroaches, and but that is not going away. It's still there, and I think of FHIR as more of an overlay on it than a replacement for it. So there is this vision of a ecosystem that has a common platform for exchanging data using FHIR. And FHIR is very much an interoperability standard. Some people at first think, well, why can't I just use that to store my data? Well, one thing is it's changing fairly rapidly, but the more important thing is it's not really semantically interoperable as the base standard. So we have been envisioning this ecosystem where everything, all of the different systems out there connect to this common platform with the healthcare data based on FHIR. That led, as you may be aware, to the 21st Century Cures Act, which was actually passed in 2016, and it specified that there should be an API. It didn't say FHIR, but that was determined by ONC and CMS later that was the suitable way to implement this API. And the other thing the Cures Act said was that individuals' data must be made available to them with no special effort by way of this FHIR API. So that's now in regulation as rules published by CMS and ONC. You probably are familiar with some of those. But spoiler alert, it's not working as good as we thought or hoped, and it's not a deficiency of FHIR, really. I mean, this is not a suggestion that we start over and build something better. I think we would wind up with FHIR all over again if we did that. But what the problem is that EHR systems are like snowflakes. No two are alike. And the data in those EHRs, even though it's presumably analogous data across them, it doesn't look the same. It doesn't look the same in a interoperability sense, and that's turned out to be a big part of the challenge. How does it get that way? Well, EHRs get customized when they get implemented, then customized after they're implemented. The hospital formularies are all different. No hospital has every available medication, and they don't code them in any particular code system. Terminology vendors come along and overlay a terminology layer and order sets, and perhaps one of the The biggest problems is that most organizations have their own local codes and their own vocabularies that they use or developed locally, particularly so in labs. And all of that means that the idea of a plug and play app store for FHIR apps is a ways off, because we've got to solve these problems first. And I'm going to talk as the afternoon goes by about how we might do that. So next, I'm going to talk about the concept of FHIR. So I want to talk about FHIR by going back before FHIR to the 1980s, when interoperability in healthcare really began. And it began not because organizations wanted to share information, but because hospitals started to have more than one system within their walls and they had to connect them. And that's when the HL7 organization was founded. That's when HL7 V2 was developed. But if we fast forward to current times, someone calculated a few years ago that the average hospital in the US has over 80 IT systems within its walls, and they still need to be connected. And that's that previous diagram with all the point-to-point connections, and it's going to stay that way. It's going to get more complex probably, and those systems do what they do very well. There's no economic argument for ripping and replacing them. Even if FHIR could do it better, that's not going to happen. The other thing is that we know that there's not only systems in the hospital, but there are systems outside the hospital increasing at an exponential rate. There are labs, reference labs, pharmacies have data, insurance plans have data, patients have data on their mobile devices, genomic sequencing labs have data. There's just a lot more data out there. And now, in that reality, interoperability now means being able to see all of the data in all of those systems for a patient or for a population of patients in real time. That's what interoperability means now, not connecting two systems together. Not only is there data in more places, but there's a lot more data. You know that. It's growing. Dr. William Stead at Vanderbilt wrote an article a few years ago where he estimated the number of facts that exist per complex decision we make in healthcare. And his estimate was that in 1980, there were about 10 facts per decision. In 2020, by exponential growth, and it's not hard to believe, there are 1,000 facts per complex decision in healthcare. And although not every decision certainly is complex, I would argue that all decisions are getting more complex as the amount of data grows and the possible treatments grow. What has not changed is the number of facts that a human can handle in making a decision. That's about 5. I like to think, like most of you, I could do 7 or 8. But I was behind in 1980, and now, like everyone else, I'm hopelessly behind. This graph, this concept has a lot of implications, that decisions can't be made unless we have computable data. Not only is there more data in more places, but there's also new data that's more complex, genomic DNA sequencing. New technologies produce new types of data, and it's just growing exponentially like the graph suggests. So with that reality, HL7 about a decade ago convened a task force and asked that task force the question, what if we created a new healthcare data standard from scratch? What would it look like? They were aware that HL7 V2, HL7 V3, CDA weren't really meeting the needs of the future. V3 was actually, has been deprecated by HL7 because it was not being used due largely to its complexity. It was too hard to implement. So with that in mind, that task force, in fact, a gentleman named Graham Grieve, who many of you are probably aware of, who lives in the outback near Melbourne, Australia, came forward with the concept that we now call FHIR, Fast Healthcare Interoperability Resources. Because all over the world, data was going from offline servers in the hospital basement to online. There were data transparency efforts. Medical records were shifting to a mix of coded data and narrative data. So to explain what FHIR is in its essence a REST API, a representational transfer state API. That's the basis of everything we do on the internet every day, Google and Twitter and Facebook, but probably the easiest way to explain it is travel websites. And if you go to your travel website, whichever one you like, and you put in that you want to go from Fort Lauderdale to Boston on June the 10th, you see flights on different airlines with a departure time, price, and so forth. And it's not because that website downloaded all the airline schedules, it's because the airlines have agreed on how to represent the data in an airline flight, how to ask for it and what you get in return. So that is what FHIR is for healthcare. It's the same technology, and it's the meaning of the data in healthcare, and that's where it gets really complex, because data in healthcare, as we know, is very complex, far more so than airline flights and almost everything else. So there are a couple of concepts to understand about the FHIR specification and how FHIR works technically, but also how the data model, healthcare data model underneath FHIR is built. The first concept is resources, and that's resources as in Uniform Resource Locator, URL. So that FHIR resources are logically discrete data concepts, not a data element, but a concept, and within that concept are the data elements that you need to describe that data concept. So within the resource are multiple data elements. For example, the patient resource, its birth date, first name, last name, gender, and so forth, all the things you need to describe a patient, including a medical record number and a primary provider. Then there are other resources like medication, care plan, family history. All of those discrete concepts make up FHIR resources, and they have a known location that looks like a URL. It means it's located on a server somewhere, maybe on the one you're on, maybe on the internet somewhere, and all of those resources have a meaning, which is the FHIR specification, which defines what those resources mean. That's the data model underneath the FHIR specification. And it's a work in progress as FHIR gets built out, if you will. And we'll talk a little bit about that in a bit later this afternoon. But it's by no means a finished work. The other thing to understand in FHIR is FHIR profiles. So FHIR profiles are everything you need to customize a FHIR resource for a particular use case. And I use the word customize, which makes sense, but what the people usually say is constrain the FHIR resource for a particular use case. That's what a FHIR profile is. It includes vocabulary bindings, code system bindings, FHIR extensions, whatever you need for your particular use case, and we'll come back to extensions in a minute. But very importantly, profiles are not part of the FHIR standard. They're what you build with the FHIR standard. Now, there are some profiles that have been balloted by HL7 and FHIR on the FHIR website, but they are not part of the base FHIR standard. They are what somebody has done with the standard to make it more interoperable. I said that the FHIR data model, the resources are very flexible so they can be used in a lot of different use cases. Well, flexibility is the opposite of interoperability. You have to get rid of the flexibility to make something really interoperable. So that's what FHIR profiles are about. We're not going to talk about everything about them today, but the idea that that's where the interoperability is very important. So interoperability comes from systems using the same FHIR profile, not just using FHIR, but using the same FHIR profile. So the good part of that is when data is specified according to a particular FHIR profile, you can use it in different interoperability paradigms without having to transform it. That's not true of any other standard, healthcare data standard at all. So suppose you had a lab test result that you got from a FHIR REST API, and you take that laboratory result specified as a particular FHIR profile, you can put it in a message and send it to another system. You can put it in a document, like the equivalent of a CDA document, and send it somewhere. Or you can use that, that lab result in a decision support service, because when data is in a particular FHIR profile, it is computable just as it is. You don't have to do something to it to make it computable. So interoperability across paradigms is a very important feature of FHIR. So they say that true interoperability is when we say something and we both mean the same thing. But reality is that it's not us as humans that have to mean the same thing, it's our computer systems that have to mean the same thing. We're really good at figuring things out. Computers, not necessarily, artificial intelligence aside. So to illustrate what I mean, suppose that two individuals had never seen this animal before, and one of them says, it's a white horse with black stripes, and the other one says, it's a black horse with white stripes. Well, they figure out that's the same thing pretty quickly. But to a computer system, that's absolutely two different things. You have a different definition of what that is, and it may be true that we could program the logic in to understand that those are the same thing, but there are so many things in healthcare that can be reasonably described in two or more different ways that would never work with all the healthcare data. You may have noticed my prop up here to remind you of the significance of this, this point. So we call those descriptions, those detailed descriptions of data, clinical information models, detailed models. So they are all of the vocabulary bindings, all of the relationships between the data in that use case, all of the relationships of that data to other data outside. And if that's starting to sound like a FHIR profile, that's exactly what it is. A FHIR profile is an implemented clinical information model. That is the important point. Well, have we used models before? Well, there have been modelers for a long time, and we've used models in healthcare, clinical care for a long time. We call them documents. And that is a data model, a very important one. And suppose to explain the significance of that and what FHIR has to do to replace documents, suppose you printed out a history and physical on an individual, and you took a pair of scissors and you cut it into data elements. And you pick up a piece of paper and it says diabetes type 2. Well, you know what that is, but what you don't know is whether that's a condition the patient has right now, or whether it's a condition they had before they had weight loss surgery and lost 200 pounds, or it was a condition that their mother had and it was in the family history. So it is the relationships of data that are important. That's the model, and that's what we have to reproduce with FHIR because it's not going to be a document format. It has a very different structure, and we're going to talk about that as the afternoon goes by here. The other thing that it means is that when we have a use case, we're likely to need more than one FHIR resource to represent the data in that use case, and each of the resources must be profiled for that use case. So suppose we had a procedure, whether it's a laboratory test or an imaging procedure or even a surgical procedure. All the procedures have some things in common. So there are resources that represent those things in FHIR. The FHIR procedure resource would tell you in the details that we can't see from 20,000 feet, that FHIR procedure resource would tell you what procedure exactly it is. There's a patient resource upon whom the procedure is performed. There's a practitioner who performed the procedure. There is a condition that's the reason the procedure was performed, all of those being FHIR resources that would be profiled for this particular use case. And there is, in most cases, the procedure takes place within an encounter. There's a FHIR encounter resource. And the most procedures, a lot of procedures, wind up producing a diagnostic report. That's another FHIR resource that would be profiled for whatever procedure we're building a scenario for. So a couple of other important things about FHIR. One is terminology binding. And in the FHIR specification, there is the concept of terminology services, a terminology module, and what is referred to as a terminology server. So it's a server where data is represented for different code systems and different value sets, accessible to any application that needs those value sets or those code systems, and the FHIR specification includes the operations to manipulate those terminology code sets and value sets as part of the specification. It's a very valuable thing in FHIR because it means that different organizations, different apps can share exactly the same value set and reach interoperability more easily because of that. So, for example, if you were building an app for treating bacterial pneumonia and there's a list of antibiotics that could be used to treat bacterial pneumonia, you would want to have that value set and probably a mapping to other code systems, different code systems that might have different codes for those same antibiotics to enable your app. And once you did that, you can share that value set with other apps or other organizations that are using your app for treating bacterial pneumonia. The other thing that I said I would come back and talk about is FHIR extensions. So when the FHIR specification was started, one of the design principles was that they should only represent data elements in the base specification if they were already present in 80% of systems. It's a rule of thumb, the majority of systems. That was to keep the whole implementation and the whole definition of the FHIR specification simpler so it would be easier to work with. Obviously, you would often need, in a particular use case, some other data element that's not part of that base specification, so you use a FHIR extension. And the FHIR specification does specify how you build a FHIR extension and for a data element that's going to extend a particular FHIR resource. And the other requirement in the specification is that if you do create an extension because you're adding a data element, you must publish that extension to a publicly available URL so that somebody that receives that data can discover what the meaning of that FHIR extension is. It certainly promotes interoperability to be able to do that. And those extensions often become part of a FHIR profile or implementation guide. As an example, which is not a clinical example, but easy to understand, suppose you operated a facility in a country and you were involved in medical tourism, you saw patients from other countries. Well, you would want to know what their nationality was, very likely, but nationality is not an element or is not represented in the FHIR patient resource. So you would create an extension for nationality, extension on the patient resource, publish that, and that's the idea of an extension, whether it's clinical or not. So the last thing I want to talk about is FHIR implementation guides, sort of the end game of FHIR. And FHIR implementation guide, the implementation guide is actually a FHIR resource, and it is for a particular use case, all of the FHIR profiles you need, the extensions, the vocabulary bindings, all in this implementation guide in machine-readable format, which means you can validate your implementation against those FHIR profiles. And everything in the FHIR implementation guide is also there in human-readable format with examples and explanations of what you're going to use this implementation guide for. The FHIR implementation guides, as I say, they're sort of the end game. They become the important way that governments, the US government included, specify what is required in federal regulation. They don't just say you need to use FHIR, they say you need to implement in your organization a particular version of this implementation guide for a particular use case. So that is the concept of FHIR. We're going to go back and take a little more detailed look, take a deep dive into the FHIR specification, and if it's deep, it's quick. It's not, you're not going to know everything about FHIR, but I want to talk about how you navigate the FHIR specification and what's there. And I should give credit to my colleagues, Dr. Laura Harriman, who's a nurse informaticist at University of Utah, and Dr. Jim McClay, who's the Chief Informatics Research Officer at the University of Missouri. I usually do this workshop with them, and many of the slides come from them. Let me start out with reviewing what we've just talked about, the sort of basic concept of FHIR. So FHIR is meant to be computable, shareable healthcare data objects. That's what the resources are. They are self-contained. A resource is the smallest thing you can exchange in a FHIR exchange. And they are designed to be like other things on the internet. They're designed to be findable, usable, and extensible to take advantage of the internet technology. A lot of times when we start out learning about FHIR, and much of the time when we talk about fire, we're talking about the clinical data. So the clinical resources, the ones I mentioned earlier, or I mentioned a few of them earlier. The truth is that out of the approximately 150 fire resources, half of them are not data. They are other things that make up the fire specification. But there are, importantly, a number of clinical data resources like allergies and medication and lab results and so forth, observations. There are also basic fire resources that have to do with making the fire, computable and creating a way to organize and display the data for humans. So there are things like a list resource that is used whether you're making a list of a patient's medications or a list of patients that a provider has in the hospital. It uses the same FHIR list resource. Part of the design principle of FHIR is to reuse things as much as possible. It makes coding easier, as many of you probably realize. And then there are the workflow resources like care plan and encounter. And there are a number of administrative resources that are the physical entities, if you will, patients, related persons, organizations, which might be a hospital organization or a specialty clinic. All of those administrative resources obviously essential to the operation of healthcare, even though they're not healthcare data. And then there are a number of resources that are neither organizing data nor representing data, but are the way we specify the rules, if you will, for fire profiles and so forth. Those are also fire resources that we're not going to talk about in any detail today. This slide is a list of things that we're not going to talk about, but if you're interested in actually building an implementation, you or the implementers you work with are going to want to look at these modules that the fire specification has for various purposes. There's a terminology module, there's a security module, there's a conformance module, and so forth. All of that is laid out in the fire specification. Fire specification is fairly well documented. It's not going to be a New York Times bestseller, but it is readable, and you can find a lot there, including if you go to the landing page for FHIR, there is a here's where you get started if this is your first time link, and everything in the fire specification is a link to other parts of the fire specification. So now, taking a little bit deeper dive into the specification itself, and it is at hl7.org/FHIR. That will take you to the landing page. That page is different from what it was 2 months ago because they just published a new version of FHIR. You may be aware, FHIR Release 5 has been published, and this URL takes you to the most recent published version of the FHIR specification. There's a little bit of a risk now that we get to the wrong page when we're looking at something because for FHIR Release 4 was the release for several years and for the current government regulations, and there was no reason to worry about much else for all this time, but now all of a sudden you're maybe implementing FHIR Release 4, but when you go to the specification, you wind up on Release 5. Oops. So this is zoomed in. This is obviously not the whole page, but at the top of the page, you'll see tabs for a number of places you might want to go, And very importantly, you see this yellow box at the top of the page that says, if it's not big enough to read, that there's a directory of previous versions, and those are actually links you can click on to go to release 4, DSTU2, and so forth. So you can get there from that landing page. You just have to be careful that you know where you were and where you want to go when you're working with the specification. And as I said, you may see at the bottom of the page, it says there's a first time here. So the FHIR specification is laid out with different levels of content, if you will, including the resources, FHIR resources, but not just the FHIR resources, because there's level 1, which is the very basic content of the FHIR specification, the different machine-readable formats, the different API specifications and so forth. And everything that's in the FHIR specification, there's also a link that you can download everything from the FHIR specification, like the examples that are used in all of the different FHIR resources. There's actually a link, if you wanted to download all of those examples and a number of other things that you can download in whole what's there. So there are these base level 1 content in the FHIR specification, and then level 2 is the things that implementers need to implement the specification. And this includes terminology, conformance resources. All of these words that you see are actually FHIR resources that you can, and they are all links that you can go to that. Then there's the administration level of, as I mentioned, organizations, practitioners, practitioner roles. So FHIR is not just about the clinical data, but you could actually build a whole implementation around a healthcare system using FHIR resources. And then we get to the clinical resources, the diagnostic resources, and the medication resources. And importantly in FHIR, different from what we're used to in medication management, FHIR actually has something like 8 resources related to medication. There is a medication resource that's the name and form of the medication, but there's a medication request that is the equivalent of a medication order or prescription, and then separately there's a medication dispense resource, there's a medication administration resource, and there is a medication statement resource that's actually being changed in the coming version of FHIR. Medication statement is what a patient says they're taking as opposed to what they were prescribed or what's on their medication list. It's the medication statement is, yeah, but I'm actually taking this twice a day because I thought it helped. So there are a number of different medication resources, and it's a bit hard to translate the way we're accustomed to doing medication management into those FHIR resources. For one thing, EHR systems don't tend to capture what a patient says they're taking, unless it's in narrative. Yet that's the way we represent the actual use of a medication, and that resource is being changed to the medication usage resource, which will be what anyone says, patient or provider, clinician, that a patient is taking. There are various workflow resources, and importantly, there are financial resources as well that include insurance coverage, insurance claims, and all of the things that are part of the health care provider or health plan payer ecosystem, and because they are also part of FHIR, it's easier to combine that data, if you will, between the financial and insurance side of things and the actual clinical care side of things. So I'm not going to spend a lot more time on this view of the FHIR resources, but it's all there, fairly easy to figure out and click through to see if there's something you're particularly interested in. There's also a level 5 that doesn't show on this zoomed in slide, that is the clinical reasoning part of FHIR, the evidence-based medicine part of FHIR, where there are resources that allow you to deal with actual medical literature, best practices, and evidence for things to create decision support based on clinical reasoning and evidence-based care. You'll find on the FHIR specification there are several different representations of all the resources. There is an alphabetical one. This one you're looking at is by category, and next to the name of each FHIR resource, and you may know or may have noticed that the names of FHIR resources are always concatenated. So care plan is one word, not two, and so forth. But next to each one of these resource names is a number from 0 to 5, or a capital letter N, which is a symbol for normative, and I'll talk in just a second about what that means. So part of the FHIR specification is a FHIR maturity model, applied not to the entire FHIR specification, but to each FHIR resource. And it's based on objective software maturity tools from the past, so that a FHIR resource, when it's first proposed, if you will, and there are a few that are newly proposed, when it's first proposed, it's a 0, maturity level 0, which means it's draft, it hasn't been implemented, and then it goes through stages of testing, actual using it in connectathons, FHIR connectathons, which are something that HL7 has 3 times a year, and it has to be published in at least 2 release cycles to graduate to the higher levels of maturity, and to be used in multiple countries to reach the highest level of maturity. And then there is normative, which means this FHIR resource or any other standard that's labeled normative is expected to be stable for the foreseeable future. There will be no incompatible changes made to that resource going forward. And this is something new, that this is applied at the resource level, because in the past, standards have been normative or not normative as a whole, the whole standard. But FHIR is different in, as I mentioned, the way it's being developed and built out slowly. But I've started to think of it like the other technologies we use today that are not final, like the iPhone. We know now that every year or 2 there's going to be a new model of the iPhone. It's going to be better and have more functions, and maybe some that didn't work out will be dropped, but I don't expect there will ever be a final iPhone. So to me, it's the same concept with FHIR. It's continuous improvement of the standard as it's used and tested. Out of the about 150 FHIR resources that exist now, 13 of them are normative. So not a lot of the resources are actually normative, and most of the ones that are normative are not data resources. Now, the patient resource is normative, the observation resource is normative. Most of the other normative resources are actually part of the FHIR infrastructure, if you will, and not data resources. So I want to take a look at one resource and talk about what you're looking at. They're all, by design, laid out in the same way. This is what's usually called the tree view of the resource. This is the patient resource, which, although not clinical, is a good example of how the FHIR resources look, and an understandable one at that. So the left-hand column is the name of the element that makes up that resource. And in the next column is the flag column I'm not going to try to talk about. The next column is cardinality. So how many times can that resource, that element, how many times can that element appear in an instance of that FHIR resource? So you see numbers like 0.1, 0.*. 0 means you don't have to have that element. You can have a valid instance of that resource, patient in this case, and you don't have a value for that birth date. You don't know the patient's birth date. You don't have to have a valid resource. If you do have a birth date, you can only have one. You might think that's unnecessary to have that in the specification, but if you think about it, I mean, we all know that's true, but computers don't know that's true. As long as the date's properly formatted, a computer would think it's fine for somebody to have two birth dates. So there are a lot of things that are there for validation and quality purposes to be able to validate data that you have is specified as FHIR. Then and there are no examples of this in the patient resource, but if the cardinality is 1-to-1, that means that you must have a value for that particular element in that resource to have a valid instance of it. And you can't have more than one value. 0 or 1 means you can have as many of those as you want. In this, I guess we can't see it here, but there is a next of kin emergency contact type element for the patient resource, where you can have as many emergency contacts as you have, and they can be included in the FHIR patient resource. Then the next column, which is in blue and is a clickable link, is the data type for that particular element. And I decided to not try to talk about data types today because it's a somewhat complex topic, but it's important that every element in the FHIR specification has a particular data type that it must be that element must be represented as that data type. That's certainly essential to interoperability. And then there are data types in healthcare that are what are called complex data types, where you build them out of the primitive data types as they're known. And there are things in healthcare like timing intervals, where the time in a research study or a care plan for a patient from when something occurred to the current time, those types of data types are part of the FHIR specification when you need to represent different concepts of timing, like intervals or how long before there are a number of different complex data types that you can find by clicking on one of these links. But as I said, they specify exactly what data type must be used for each element. And if you click on that link, it will show you what that data type, the definition is. Then the rightmost column that you're looking at is the value set for that particular data element. Some value sets are required in the FHIR specification, so to have a valid instance of a FHIR resource, you have to use that required value or a value from that required value sets. Some of them are not required, some of them are extensible, and some of them are just examples of a value set you might use. But when there is a required value set, it is indicated there. So like gender, administrative gender, which is the equivalent of what your DNA says you are, can only have one of four values: male, female, unknown, or can't remember. In any case, required value sets are part of the specification. They are not something that you have to go on to a terminology server to look up. That's value sets that are not required and have been created for a particular use case. So to talk a bit more about terminology in FHIR, FHIR, as I've said, is a flexible data model. So it doesn't require that you have coded data. In fact, it allows you to have structured or even unstructured data in a FHIR resource if that's what your profile describes. But it does give you a way to specify a value set, a code system. If you think about it, the code from a code to the computer, a code is of no value if it doesn't know what code system it came from. So both of those are requirements in the terminology module of FHIR, that if you specify a code, you have to also specify what code system it came from so that the system you're using can look that up. Certainly the coded data elements are the only way to get to semantic interoperability and using the same code for the same concept and not allowing optionality, which, as I've said, is the opposite of interoperability. Using coded data certainly makes data more useful for decision support, for quality metrics, and so forth. So FHIR makes all of that possible, but it doesn't require it. You can create FHIR profiles and FHIR implementation guides that are not well designed, that are not tightly, precisely defined, and you don't have interoperability. So this is what a diagram of the terminology services in FHIR looks like. You have a code system from which you define a set of values for a particular element, and we call that binding that data element to that value set. Then when you have an instance of that particular element, a value in it, you can validate against the FHIR terminology server whether it is a valid code that can be in that, used for that element if it conforms with the vocabulary terminology binding of that particular element. This, as I've said a couple of times, is something very different about FHIR that is not part of other standards. There's a way to do it in other standards, but not easy to do as it is with FHIR. So there are different levels, types of terminology binding in FHIR. I mentioned required value sets, and then there are extensible value sets, which means that you as an implementer can extend the values that that can be in a particular value set. There are preferred value sets where, for the sake of promoting interoperability, there's a preferred value set, but if you have a reason to create another value set for that element to suit your use case, that is allowed under a preferred binding. And then there are examples, which I mentioned, where somebody has just created for example, this might be a value set that would fit in this data element. So what it looks like in code as example terminology binding for birth sex, which is, as you see, the strength of that binding is that it's required to use this value set, and then there's a URL that represents that value set where you can find it on the HL7 servers. So that is the idea of this computable terminology, if you will, which doesn't require downloading code tables to your system to use them. So FHIR operations are also part of the specification. I'm not going to talk a lot about them. I don't know a lot about them, except that they are an essential part of making FHIR interoperable. But as examples, you can use a FHIR operation to validate a resource as to whether it is a valid instance of that particular resource. You can use a FHIR operation to generate a document reference, which means a document reference means there is a document somewhere that doesn't have to be FHIR data. It can be a PDF or some other form of document, but a document reference is a pointer to where that document is and what type of document it is. So there are a long list of these FHIR operations that would be used if you're actually building an implementation of something. Here's a zoomed down view of the beginning of the operations. You'll see that the top section is operations that can be applied to any FHIR resource. And then after that is a much longer list of operations that are specific to certain FHIR resources. For example, the apply operation. So in FHIR workflow, there are activity definitions, which are tasks, if you will, that might be part of a care plan. They might be part of a procedure in a facility, but those activity definitions are instructions, if you will, on executing some activity. Those can be specified in a care plan, for example, but then to generate a care plan resource or plan definition resource that is a template, if you will, for a care plan. To create an actual care plan for an actual individual, you would use these apply operations to convert that care plan template to an actual care plan that would be for a particular individual. So a number of the FHIR resources are definition or plan resources. So they do not apply to a particular individual, either patient or provider. They apply to the concept of that resource and what you're going to do with that resource. So there's a plan definition for care plans and for other types of plans. There is a structure definition resource that is the way you specify FHIR profiles to be able to share them with other systems. So many of the FHIR resources are not data, as I've said, but are ways to specify what you can do with the data resources. The next thing I would like to talk about is organizing information with FHIR. And I've already mentioned the list resource as a way of organizing data, but there are a lot of things that we may not usually think of as lists that really are essentially a list, like a patient's social history is actually a list of social history items, and the same with a past medical history or surgical history. It's a list of past events, if you will, or observations. But one thing about the list resource is it doesn't actually require that everything on the list be the same thing. So a medication list, everything on the list obviously is a medication. But for something like medical history, social history, the items on the list might be different, might be unlike items. It's still a list. It's still part of organizing data in healthcare, and it's enabled by the FHIR list resource, which we're in our hands-on section actually going to look at how you create and enter things on a list. Now this, which is a little bit hard to see, is a simple story about a 12-year-old who goes to a physician because they have an ear infection. They get prescribed amoxicillin for the antibiotic for the ear infection. They come back a few days later because they're having an allergic reaction to the amoxicillin. So the colored text you see is what FHIR resource you would use to represent each of those data concepts in this document. So you're essentially replacing each of those data concepts with a FHIR resource that has the data elements that specify exactly what that instance is. Then it looks like this as a diagram, a diagram of the FHIR resources that are in that document. And when we put a bunch of FHIR resources together for something, it's called a bundle of FHIR resources. It's a common way to send data over the wire as FHIR. And there is actually a bundle resource in FHIR that tells you what this bundle's purpose is and other details about this particular bundle. So a document is a bundle of the resources for the data in that document plus a FHIR composition resource. And the composition resource tells you what this document is and how those resources are arranged in this document. So you wind up with a FHIR document that you send as a bundle. So this is an example diagram of a bundle and what it might contain in terms of FHIR resources, just sort of a generic example. What's important about documents in healthcare is that many times they need to be signed for attribution purposes. A document needs to have a author, a creator. That's one use of this bundle resource and creating a document using FHIR is that it's possible for that to be authenticated against some individual or organization that created the document. Then the next FHIR resource I wanted to talk about is the FHIR questionnaire resource. And I will admit that this is my favorite resource because you can do more with it than you can, I think, any other single FHIR resource. A lot of things in healthcare are questionnaires. I mean, even a registration form is a questionnaire. It may not have question marks in it, but it's, you know, what's your first name, last name, where do you live? Those are all questionnaires. Many of our encounters with patients, the history we take is essentially a questionnaire. The evolving concept of patient-reported outcomes, being able to capture from patients what they feel about their treatment or a new drug they're using, patient-reported outcomes are essentially a questionnaire. The questionnaire resource allows you to organize a simple flat series of questions, but it also has the capability of branching logic so that if the answer to question 3 was no, you skip to question 7. That kind of structure for a questionnaire. And then, as you might imagine, the output of that response to the questionnaire, it uses the questionnaire response resource. That's what actually gets stored on a FHIR server or FHIR repository or sent somewhere as a bundle, once again, because this is another type of document. The response gets sent and put into a FHIR repository. So one of the things about FHIR servers is they can have a REST API, but they also can have a bundle API so that that FHIR endpoint that you're sending something to knows to expect a bundle and is enabled to do bundle transactions. So many things in questionnaires, many things in healthcare are questionnaires. Now, I think of questionnaires and documents as a low, easy entry point into FHIR, because you can do a lot of things with those FHIR resources, and you don't have to be compliant or integrated with another system. You don't necessarily have to be following government regulations around specific vocabularies or what. You can build something in your own environment as a FHIR document that's simply getting sent to some other individual or system as a document, and you can collect these questionnaire responses and do analytics on that as FHIR data. And you don't have to know a lot about the rest of the healthcare system you're working in, but a lot of times you can create something very useful in your own immediate work environment using the FHIR standard. And it's not a bad way to start learning about the FHIR standard. And I see these types of things going on in a lot of organizations where people are developing FHIR apps locally that utilize the documents, questionnaires. Appointment making is another low entry for FHIR because there are FHIR appointment-related, scheduling-related resources. You can build something that takes advantage of the technology of FHIR and not have to know a lot about the rest of your healthcare system. So I think of these as good ways to get started for the reason that I mentioned earlier, that it turns out that plug and play interoperability with FHIR is really hard to do. that's one of the reasons I see a lot of organizations, a lot of individuals in organizations developing things locally because it's fairly easy to do. They can make use of it, and they don't have to worry about whether it works in another organization or another state or whatever. It works for them. So those are, to me, good entry points into the FHIR standard. And then the questionnaire response is, as I say, it's the bundles that come out of the response to the questionnaire. There's another concept that's been used a lot, and they've published some implementation guides in HL7 that is called structured data capture. It was not an idea that was original to FHIR, but FHIR makes good use of this concept. What it means is you have a questionnaire, and you have implemented it as a FHIR questionnaire, but some of the answers to some of the questions are known to your EHR system or some other system. And if your EHR system, which it's required to have now, if your EHR system has a FHIR API, you can query that API for the answer to that question in your questionnaire, which the patient, if they're the subject, or the clinician, if they're the one that's responding to the questionnaire, may not know those pieces of data that the EHR knows, so you can automate the process of answering those questions from the EHR. You could, as an example, if you have a questionnaire asking a patient about their current medications and whether they're having problems with them, you could actually pull their current medications out of the EHR system, and then they are answering a questionnaire about their specific medications, and many other. The other use of this structured data capture is that the government has funded a lot of the development of the structured data capture because a lot of required reporting forms for government are essentially questionnaires, and they need data that comes from EHR systems and other systems, and they have been able to use FHIR as a convenient way to get those questionnaires answered, including pulling data out of systems and putting it in the questionnaire response from those systems without a human having to intervene. And then when there are questions that only a human knows the answer to, then that's left to the human to answer. So I've said a bit about FHIR profiling. The most important thing I've said is that interoperability requires that two systems are going to use the same FHIR profile to exchange data. There are a lot of different contexts for FHIR profile, each one being a use case, and they can be authored in a structured manner to create a FHIR profile that fits a particular purpose. I would imagine that maybe one of the places that AI can help us is in helping to author profiles. I think it is a structured process, if you will. And there are three main aspects to creating a profile. One is constraining elements in a resource. So suppose you're the NHS in the UK, everybody has an NHS number. The FHIR patient resource allows an individual to have multiple identifiers, medical record numbers. If you're building a profile for something in NHS, you would want to allow only one value for that particular element, and it must be the NHS number. So that's a simple concept of a FHIR profile. And the other thing that profiles often do is change the binding for a particular value set for an element, depending on what the use case is. And then the other common modification that a profile makes is to add an extension that doesn't exist for your particular use case. But that's what profiles amount to. And then when you have an implementation guide, you wind up profiling all of the resources that are needed for that particular use case, and that's packaged together is the implementation guide. So I already mentioned some of these. The other things that can be modified in a FHIR profile that aren't about the data itself is what elements of an API can be used in this particular profile. And once again, because I think it's very important, the FHIR extension mechanism, where there is a requirement that when you create an extension, you publish that definition of that extension publicly. Now, there are some extensions, like there are some profiles that are in the FHIR specification, but they are not part of the FHIR standard, the base specification, but they are on the FHIR pages and have been, in most cases, balloted as part of the FHIR specification. If you think about it, there are a lot of things that are extensions but aren't very clinical or terribly exciting, like postal addresses. Every country needs an extension for their format of postal addresses. So there are things like that that get included in the specification or in a directory somewhere, registry somewhere, because they're going to get used by a lot of different people and organizations. So I've said quite a bit about implementation guides, and they are a collection of profiles, so they can do what profiles do, basically. And in the US currently, the federal regulations point to certain implementation guides, like the US Core Implementation Guide, which is the implementation guide for implementing the US core data elements, sometimes referred to as the US CDI, which is the ONC's specification of what data elements must be included in a FHIR implementation in the US. They are FHIR profiles, but they are not the kind of interoperability that we ultimately need to get to. I've said that profiles are for a particular use case. The limitation of the US core FHIR profiles that are required in law, the limitation is that the use case is the whole US healthcare system. So it's much too broad to expect precise interoperability when the use case is as broad as the US healthcare system. So that's more or less on schedule. I was going to stop and see if there are questions I could answer, or the next thing we're going to do, and I was going to get set up for it before we take a break here for about 20 minutes, get set up for the hands-on portion of this workshop. And it's the script you have. If you don't have one, raise your hand and we'll get you one. The script in the first 2 pages describes the tool we're going to use, and then a simple story about an individual who's going to a primary care provider with a tender elbow. So the tool we're going to use for this is called Graph Builder 2, and it's a part of a larger suite of tools that are called ClinFHIR, and it's at clinfhir.com. It was developed by Dr. David Hay in New Zealand, who's a GP turned software developer, is one of the co-chairs of the FHIR management group in HL7. I refer to them as the high priests of FHIR. But this, very importantly, this tool is not a FHIR app. It's not an example of a FHIR app. It's a way to design your data model for FHIR or in FHIR, and what FHIR resources and elements in those resources you would need for whatever use case you're developing something for. So if you think about it, if you had an idea for a FHIR app, and whether you're an app developer or not, you might have the idea. In fact, that's often the case. Somebody who works in a healthcare environment has an idea. The first thing you need to do is determine what FHIR resource, well, the first thing you need to do is determine what data does my app need to access, or what data is it going to create when it's used, and then how do I represent that data as FHIR resources, and what data elements in those FHIR resources do I need to have values for to make my app work. That's sort of the logical starting place of developing any application in FHIR, or anything else I would imagine, but in this case, FHIR. So what the Graph Builder app does is allow you to pull down an empty FHIR resource and then put values in it for the things that you're interested in putting values in, and then connect it to other FHIR resources. So the important thing about thinking about what FHIR data looks like is it's not a document, it's not a relational, not a set of relational tables, it's what's called a directed graph. And what that means is the FHIR resources that are these discrete data concepts point to other FHIR resources. And they point in a computer sense by a server reference, but in a human visualize it in your mind sense, they're pointing to another resource, and this Graph Builder app actually gives a graphical representation of the resources as we add them to the scenario. They point to another resource. So a medication resource points to a patient resource as if to say, I am this patient's medication, or I am this patient's lab result observation. And those are connected. It makes it easier to query for data in a computational sense to get all of the resources that are connected to the patient. So in a system, a patient only has one patient resource that's their patient resource. Likewise, a provider in a system only has one provider resource. But it is this idea of data that's connected by these references, making it computable, but making it hard to, at least for me, to envision the way I usually have thought of healthcare data. The Graph Builder tool is a way of internalizing this structure of the data, but also a way of going out and using the tool to build something that you might want to build. The ClinFire suite of tools, which also allows you to construct FHIR REST queries and other things that you might want to develop or test. It is a web app. It is free, not open source, because it's David Hayes' web app that he maintains. For the past year, InterSystems has sponsored him to maintain the ClinFire tool. It gets used by hundreds of folks all of the time, presumably developing applications or testing different ideas about a FHIR application. And the story, as I said, in our scenario today is really a fairly simple scenario of an individual who has a history of asthma and diabetes, going to a primary care provider because they have a tender left elbow, and during that office visit, they reveal that there's an e-cigarette user. All of those things play into the little data scenario we're going to construct with FHIR resources. So we're about 10 minutes ahead of schedule, and that's good. But we were going to take a 20-minute break. So why don't we reconvene at, should be 10 after 4. Any questions before I? Which one? Yeah, the slides the slides I will share, except the video one is, but the others absolutely, yes. And in fact, I had planned on doing that because there are links in many of those slides to the things we didn't talk about. That. Thank you. Okay. No other questions. We will reconvene at 10 after 4. So I have recorded myself going through the steps with a screen share. That decreases the extent to which you realize how bad my eye-hand coordination is. This is another short URL which will take you to the project as described in the script for this. And it should actually open the Graph Builder app for you. Starting now with the hands-on exercise. Step 1, if you would type into your browser address window the URL https://bit.ly/3 capital H WWR capital B capital O. You should see that on my screen already entered. When you hit return, that should take you to this window where you see in the middle a green button that says download project. If you click on that, you should in a moment see the home screen of the Graph Builder 2 app with the GS 2023 problem list exercise project in the upper left-hand corner. Now proceeding with step 6. I'll pause for a moment and let everyone get to this stage. Now, if you go back to the previous tab, you'll find the Graph Builder app. Next, number 11, adding additional FHIR resource instances. Using the Add a New Resource Instance tab, the green tab near the upper right corner, click on that. Now, if you go back to the previous tab, you'll find the Graph Builder app still open. Now, on step 10, in the right panel, click on Resource Content, the tab to the very right, and you'll see a window open with 3 tabs. The first, FSH, is FHIR shorthand, which is an editor we will be introducing later. The other 2 tabs, JSON, JavaScript object notation, and XML, extensible markup language, are the 2 machine-readable formats available for the FHIR specification. 2 of the 3, I should say. Next, number 11, adding additional FHIR resource instances. Using the Add a New Resource Instance tab, the green tab near the upper right corner, click on that and into the filter box, enter practitioner for our primary care practitioner that the individual is seeing, and make up a name for that primary care practitioner. Enter that into the display box. Remember, this is a sticky label. Save it. And then item 11B, add a list resource. Once again, the Add a New Resource. So when you're open to this menu choice, that's all of the FHIR resources, so you could add any one of them. And as I mentioned a couple of times, when you add one of these resources, it's empty. There are no values in any of the elements in the resource. And so we put that label on it, as sticky note as I call it, just so we'll remember what we're going to do with that particular resource later. Instance, type list into the filter box. Remember, this could be a medication list, a list of patients a practitioner has in the hospital. For us, it's a problem list. Save that. And then item 11C, add a condition resource, again using the Add a New Resource instance. And this condition resource is for the tender elbow. And it's the left elbow. Save that. Now, item 12, references between FHIR resource instances. In the middle tab, click on the References tab, the second one from the left. You see the list of resources, including the ones we just added. And in the right-hand column, see the references, meaning that these are other FHIR resources referenced by a resource. Those references are the arrows on the graph. The Graph Builder app only allows one patient per scenario, so it assumes that the patient resource is the subject of all condition and encounter resources, and you see that's already been filled in the references column. Now, adding references to a resource. Number 13, click on the Content tab once again and click on Asthma. Then click on the Details in View tab in the right-hand panel. And on the right, click on Potential References in this view if it's not already clicked. If you hover the mouse over the items in the left-hand column labeled Path, you'll see an explanation of what these elements mean. So the recorder, the individual who recorded the resource item, and the asserter, the individual who is making the condition assertion. Now, click Add Reference next to Encounter to associate this encounter with the condition asthma, and you'll see that line disappears. Next, item 15C, choose who recorded the asthma condition. That would, of course, be the primary care practitioner. When we click Add Reference, that line and the other associated line disappear. Now last, the asserter of the asthma condition. Remember, this individual told the practitioner that they had had asthma in the past, so they are the asserter. If the practitioner had diagnosed it, then it would be different. Now, item 16, click the Graph tab and see the references we have added that have created additional arrows in the graph. So I don't think I've mentioned this, but one of the important things about the references is that they go with the FHIR resource when it gets exchanged later or queried for later. So this asthma condition resource, if you queried it or the source of it sent that resource to you, it's not just the condition, it's this metadata around the condition that's going to stay with that resource forever or in the future, so that you would know who said or who performed the procedure or any of those things, that it's very powerful that you get this metadata with it. Now, somebody has to put it there. You're not going to do it by hand, but presumably you would automate creating this data from a system, and you would include those important metadata items, and there's many others that can be there. but as references, so you get more than just the name of a condition when that data is exchanged or accessed. Number 17, adding values to elements using the FHIR shorthand editor to create resource instances. So click on the Content tab once again above the graph and click on the condition asthma. Click on the Resource Definition tab under the selected resource at the right, and click on the Tree tab if it's not already clicked. 17b, click on any of the elements and see an explanation of the definition of that element, the cardinality, the data type, and the value set for that element. Try this with code. You'll see it is the identification of the condition as a minimum cardinality of 0, meaning it does not have to be present, maximum of 1. You cannot have 2 codes for one condition. Click on the Resource Content tab at the right. It should still be on the asthma condition. Item 18, click on the pencil in a square symbol at the extreme right. You see that has a dialog that says FSH editor screen. When you click on that, it opens a window with the FSH editor open to the asthma condition. The FSH editor, FHIR shorthand editor, is a human-friendly editor to add values and elements to FHIR resource instances. On the left, you see the name of the element, the next column, the cardinality, and the next column, the element's data type in blue. Clicking on the blue text for the data type next to any value will allow you to add a value for that element. Number 19, click on Codable Concept next to Code. If you first hover the mouse over Code, you see that is the identification of the condition, problem, or diagnosis. Now, when you click on Codable Concept next to Code, this opens a filter box. Type into that filter box asthma, then click Expand. This is going out to the terminology server and finding codes that have the word asthma in them. Sometimes there's a delay in getting that list of codes. If you get an error, just click Expand again. You see there are a number of different values for the condition asthma, some of which would not really be appropriate for this problem list condition, but there are a large number of codes that might be appropriate. This is an example of why we need value sets to limit the number of possible values for an element so that there is no chance to have different individuals choose different codes. We don't know much about this individual's asthma, so I will click the SNOMED code in the left-hand column next to just asthma. That you see now has been added to the FHIR shorthand in the middle window as the last line. Now click Codable Concept next to Clinical Status. Then click Expand to expand the value set for this. You see a short list of possible values because this is a required value set. We were told in the little story that this individual had not had asthma for 5 years, so it would be reasonable to choose inactive for their asthma condition, for the clinical status of their asthma condition. Now, click the Save button in the upper right-hand corner. That has saved the FHIR shorthand and closed the editor. Now click on the JSON tab in the right panel. You'll see that that panel is empty. Then click the double circle arrows, and as you do that, you'll see that that is the action to rebuild JSON from the FHIR shorthand. When you click that, in a few seconds, you get JSON code, which is compiled from the FHIR shorthand, and you get a indication of all good. That indication is that the FHIR shorthand editor has gone out to the FHIR conformance server and validated that the code generated is valid with respect to the FHIR base specification. So this is a demonstration of how validation works. If you made an error in that, if you added a value that shouldn't be there, you would get an error. But this is the, in actual implementation of something, being able to validate data that you receive as being valid instances of FHIR before you use it for some computation when it's not valid is a very useful, powerful aspect of FHIR that you can do this validation in the background to check data quality, if you will. And I will say, so the FHIR shorthand tool was created by some individuals at MITRE about 4 years ago. Prior to that, when we did something like this, we had to hand enter values into the JSON code, which was not a easy or engaging thing to do. So it's nice to have the FHIR shorthand. The FHIR shorthand editor is actually very widely used by people who are developing FHIR because it is a useful editor and has some other features that we won't talk about today. Next, 20, alternative access to the FHIR shorthand editor. Click on the Graph tab once again to see the current state of the graphic representation of our scenario. Then double-click on the patient resource for I'm a Patient, which you'll see brings up the FHIR shorthand editor for the patient resource. Now, give your patient a human name. The third line down, when you click on that, you get a dialog box. In the text, enter the full name. You can use the name in the scenario or make up a name. Then click Insert, and you see that's been added to the FHIR shorthand. Item 20C, click on the reference next to general practitioner. The patient resource includes a link reference to the patient's primary care provider. When you click on that, you see that the resources that may be referenced include the Good Health Clinic that was in the original scenario, as well as the practitioner that you have added. So the patient might get their primary care at a facility clinic rather than from an individual. You can choose whichever one you wish. Click Select, and you see that's been added to the FHIR shorthand editor. Now, 20D, give the patient an identifier, the first element in the list. When you click on identifier, it opens a box with the system being the organization that has assigned this particular identifier that you're entering. We'll just leave that blank, add a number in the value box, and then click Insert. You see that's been added to the FHIR shorthand. If you wish, you could add a gender and assign a birth date for the individual. Now click Save in the upper right-hand corner. And once again, click on the double circle arrows at the right. That generates JSON from the FHIR shorthand. And once again, you should get an all good indication that this has been validated against the FHIR specification and has been found valid. If you had entered some erroneous value or entered a value twice, you would get an error. Now click on the Graph tab if it's not already, and you see your current references, including an arrow pointing to the patient's primary care provider. So the FHIR specification actually specifies what FHIR resources can be referenced by a particular resource in a particular data element. So if the data type for a data element is reference, then you can look at the specification and see what possible resources could be referenced for that value. Number 21, building a list. Double-click on the problem list resource to bring up the FHIR shorthand editor. 21A, click Code next to Status, bringing up a dialog box. Click Current, as it's a current list. Insert that. You see that appears in the FHIR shorthand. 21B, click on Code next to Mode. Again, a required value set appears. Make this a working list. Insert that. Note that status and mode both have a cardinality of 1-to-1, which means they are both required elements. They must be present. Otherwise, it will fail validation. Next, 21C, click on backbone element near the bottom next to entry. Then click on the reference next to item, the last line. So this is an item that will be on the list. Remember, the Graph Builder app doesn't know what type of list this is, so it displays all the resources that might be on a list, including the patient. In this case, it is our problem list, so we will choose one of the conditions, click on Select, and then click on Insert, and you will see that the condition you chose is now at the bottom of the FHIR shorthand code. Now repeat clicking on backbone element next to entry, clicking on reference next to item, and choosing a different condition to be on the list. There are two choices. Then click Insert, and that has been added to the list. Number 22, click Save. Click on the JSON tab. Click the double circular arrows to generate the JSON code. And again, you see an indication that it has been validated and is all good. Now click on the Graph tab if it's not clicked and see the current status of our scenario. You can see that the conditions you have selected to be on the list are now referenced by the list as entry items. Number 23, adding values to add clinical context. Double click on tender elbow. The tender elbow is not a diagnosis, but it is a health concern of the patient and is therefore a problem on the problem list. 23A, click on codable concept next to code. This is the identity of the condition. Enter your search term into the filter string, tender elbow. Click expand. And in a moment you see that there is a SNOMED code for tenderness of elbow joint. Click on that, and it's inserted into the FHIR shorthand code. Now, 23B, click on codable concept next to body site. In the filter string box, enter left elbow. Click expand, and in a few seconds you see that there are a number of SNOMED codes indicating the left elbow. I'll select the first, that's left elbow region structure. That's inserted into the FHIR shorthand code. Now click reference next to encounter so that we can indicate this condition was identified during this encounter. Click select next to the office visit. If there were more than one encounter, we would of course be given a choice. Now click Save in the upper right corner. Click the double circular arrows to generate the JSON code, number 24. Again, we get an all good indication. The final section, social determinants of health, number 25. Click on the graph tab, which may already be selected. Now using the Add a New Resource Instance green button in the upper right, add an observation resource. Observations are, of course, many different use cases for data. Social determinants of health, most of them are observations, as are laboratory test results, vital signs, patient symptoms, so on. All utilize the FHIR observation resource. In the display, we'll type social determinants of health, and from the story that accompanies the script, we know that the individual is an e-cigarette user. We'll add that in the text and click Save. And you see that observation has been added to the graph. Now double click on that observation to bring up the FHIR shorthand editor and the observation resource. Click on Code next to the first element in the list, which must have a value in this resource. That is, of course, status, because it has a one-to-one cardinality. Click on Code, and in a moment we see a required value set with 8 values. And since we already know the value, we'll select Final, click Insert, and you see that's been inserted in the FHIR shorthand code. Now, number 29, click Codable Concept next to Code. If you hover over Code, you see that this is the description of what was observed, so not the value, but what was being observed, or in this case, the question that was asked. So we will enter something in the filter box. Do you smoke? Or something similar. Click Expand, and you see we get a fairly long list of link codes that are various ways of asking the question, do you smoke? Some of them obviously not appropriate for this scenario, so we might select one of these. I'll select do you now smoke cigarettes as of 1 month ago? And that link code is inserted into the FHIR shorthand. Number 30, click Reference next to Performer. In this case, it would be the primary care provider. It could, in some cases, be the patient themselves. Now, the performer is inserted into the FHIR shorthand. Now, choosing a value for this observation, number 31. The last element is value, and there are several different data types which might be chosen. In this case, we'll select codable concept. We get a message that there's no terminology binding in the profile, so we will instead enter a code manually. So I'm gonna stop the last 2 minutes in the interest of time. There's not a lot left here, but I want to get on to the next section of the presentation. And what I would like to do is go over a little bit at a high level of FHIR servers, FHIR APIs, what the different concepts are, and something that I find a lot of people often are not clear on. So by definition, a FHIR server is any software that implements all or part of the FHIR REST API and uses FHIR resources to exchange data. That's as close to a definition in the FHIR spec that there is, because a lot of things can be a FHIR server, and that the FHIR spec says very little about what it must be. So the minimum requirement for a FHIR server is that it must publish a capability statement. And a capability statement is a machine-readable statement that you can query for that says this server can do these things, is capable of these FHIR operations, can validate these FHIR profiles, and so forth. That's the capability statement. It can, but doesn't have to say what release of FHIR that server has implemented. But anyway, that's the one thing that to be called a FHIR server is a requirement. Something that I've noticed people get confused about is the difference between a FHIR server and a FHIR repository, because they're not synonymous. A FHIR server, as I just said, is an API that implements any part of the FHIR REST API, and a FHIR repository means you've got a data store that is FHIR resources. So a data store that is FHIR resources is a FHIR server, but a FHIR repository, but a FHIR API doesn't have to have a FHIR repository associated with it. And the other related important concept is FHIR facade, which means you have a FHIR API that meets the requirement of a FHIR API, but the back end is not FHIR. It is some other data format, some other database that is converted to FHIR, and I'm going to come back to that with an important instance. So a generic FHIR server is a FHIR repository storing FHIR resources, and a client on both the source and the consumer end of that FHIR repository. So FHIR APIs, these are the capabilities that they can have. They don't necessarily have all of them except the capability statement, the first one. So they may or may not store FHIR resources. They may allow search query for FHIR resources. They may include history and versioning of the FHIR resources that are stored. They may have validation capabilities, and they may be in any one or all of the machine-readable formats that the FHIR specification is downloadable in. And they may do transactions and or batches, and they may support various custom operations, and there are other capabilities that FHIR servers, FHIR APIs, I'm sorry, may have. So this is a very important concept that I've found over the years many people are obviously confused about, not people who are working with FHIR a lot usually, although I have seen people who are very familiar with FHIR that wrongly assume that EHRs have a FHIR repository. They do not. EHRs have the proprietary database that they have, that they're built with, and that's how they store their data. It would be horribly inefficient to create a separate store of that same data as FHIR resources. And what really happens is what I have in these 5 steps. The FHIR API on an EHR receives a FHIR query. It has to convert that to its own internal logic, go fetch the data from its database, proprietary database, convert that data to FHIR, and answer the query. And it has to do that one resource at a time. So it's a very inefficient, computationally heavy process to query a large data set using FHIR APIs. It's reasonable, in fact, efficient for a small data set, like you want to know all of a patient's current medications, that sort of thing, but not if you want a summary history of a patient or a large data set about a patient or about a population of patients. So EHRs do not store FHIR even when they have a FHIR API. And that is one of the reasons that the FHIR app world is moving more slowly than it might, because this is not an efficient way of retrieving data from an EHR unless you have prioritized somehow those cycles for that particular FHIR resource retrieval, which the EHRs, I think, are not inclined to do. So bulk FHIR. Bulk FHIR is large data sets for FHIR. Very importantly, in the US, the end of this year, all EHRs will be required to be capable of bulk FHIR export. So bulk FHIR is a much more efficient way of exporting large data sets as FHIR, and it is not an adaptation of the FHIR REST API, but rather it's a FHIR batch API that exports these batches, and they are in a different format from REST. If you want to understand that, talk to Pat Jameson over here, who's the person I would ask if I if I had to understand it better. But it is something that was not initiated at the beginning of the FHIR specification, and I think it was a little bit of an afterthought that this was going to be necessary to make FHIR really useful, that they worked on the FHIR, bulk FHIR implementation guide at a later point. So it's a batch API. FHIR servers usually have, I think, a bundle endpoint that is different from the REST API, as does InterSystems Iris FHIR server, but that is not the same as the bulk FHIR API. So if you want data, a lot of data for a patient or a large data set that crosses a patient population, that's what bulk FHIR is intended to be. What use cases are there? Well, biosurveillance, where you're looking at a population of individuals who've received acute care for some signal of some biologic outbreak, post-marketing surveillance of drugs and devices, building data sets for machine learning. If you need a large data set, once again, REST APIs are not an efficient way to get there. Federated data for multi-site clinical research trials, which is an increasingly common use case, and makes good use of the FHIR capabilities. And there's a lot of other. But as I said, it's the end of this year when systems will be required to have these FHIR APIs. Now I want to finish up by talking a bit about semantic interoperability, which is the sticking point for plug-and-play interoperability in the FHIR app world. So there are different concepts of interoperability. You are probably familiar with most of them. Technical interoperability, meaning you can just connect two systems together. Semantic interoperability, meaning the systems can exchange data and use it in workflows as it is, and process interoperability with this even more specific concept of clinical interoperability, which is defined as a clinician taking care of a patient could exchange data that would allow another clinician with the same competency to seamlessly continue that patient's care. So that's the idea of clinical interoperability, and obviously it depends on the others being present also. So why is this problem with EHR databases? What are the reasons it's not that easy? Well, one is, and this is an actual example from Linda Bird in Australia 3 or 4 years ago, looking at 3 different EHR systems and how they represented a patient with suspected lung cancer. Simple enough concept. But one EHR says, well, it's cancer of the lung and its status is suspected. Another system says it's suspected cancer located in the lung. And the third set has a code for suspected lung cancer that it uses, a SNOMED code, already pre-coordinated, as they say. So 3 different ways, easy for a human to see that those mean the same thing, not easy for a computer system to understand that those are exactly equivalent concepts. A more dramatic example of why it's hard with EHRs and the differences in their database. There was a paper that a group of a few oncologists and informaticians published last year in the Journal of the American Medical Informatics Association. And these oncologists had 68 different implementations of EHRs of 5 different brands. And they looked at 12 pieces of data. 6 of them were lab tests, 6 of them were medications in all of these different EHRs. And they had a very elaborate scheme for doing this and comparing. This was not about FHIR. This was just about how that data is coded in these different EHRs. So if you took 2 EHRs that were the same brand for these 12 data elements, their concordance index was 0.68. So perfect would be 1.0. So 2 Cerners, 2 Epics only get to 0.68 in matching up just 12 data pieces. If you took 2 EHRs out of these 68 that were different brands, then that index falls to 0.22. So that's how hard it is to have plug-and-play interoperability amongst different EHRs, and that's just for some common and a few pieces of data. So it's back to the most important animal in today's workshop. Is it a white horse with black stripes or a black horse with white stripes? And that is really the problem with the modeling not being the same, as well as this problem of the EHR just doesn't represent that same data in the same way. So what's the solution? The solution, and it's not easy to get there, but it is precisely defined FHIR profiles. They're called usually tightly constrained FHIR profiles that can be formed automatically from detailed clinical models. And detailed clinical models, there is a formalism for creating those models and coding them. And there are tools that will take a detailed clinical model and turn it into code, either in FHIR or in one of a number of other formats, so that if you have a model, it can be used across different systems and across different standards representations to represent that same data and produce semantic interoperability. Now, the other catch is that you could have a profile for a black zebra with white stripes or a white zebra with black stripes. They're both perfectly reasonable descriptions, but they are not equivalent profiles. There is no interoperability there. So the problem that's being observed in HL7 and the implementation of FHIR worldwide is that people are starting to create different profiles for the same use case, for the same concept. And that's, nobody was watching to make sure this didn't happen, because it's obvious that it could, but they're already to the point in HL7 that they've convened a project to start looking at duplication of profiles and a process to not duplicate, to somehow select a preferred profile out of more than one possibility one of the ideas is that when you select, you're not just selecting a preferred profile, or rather than selecting a preferred profile, you're selecting a preferred detailed information model for that data that can then be turned into FHIR profiles or something else. That same model can also be used to map the data in the EHR's database schema to that model. This is more complex than the idea of terminology mapping, but it's still a potential likely solution to this problem of having a preferred profile based on a tightly defined data model that can be implemented and used in both directions, if you will, for the EHR. So these detailed models have common structure and language. The data elements have to be very consistently defined in them. And the semantic interoperability also assumes that you have syntactic interoperability along with that. So the problem that we're trying to avoid is many different developers creating a FHIR profile for the same use case and winding up with FHIR but no interoperability. So the idea, although it's not been implemented at all yet, is to have, rather than those implementers creating a new FHIR profile from the base standard for everything that they're building, have a library of these preferred models that can be used to produce preferred profiles for implementation. So with that, we're going to hear from a couple of InterSystems customers using our technology. You got a question?
Could you just go back to that slide with the semantic versus syntactic?
Yes. So HL7 V2 is syntactic interoperability, but not semantic, and you cannot constrain it to semantic interoperability because there's no feasible way to do that. So this is a diagram of, I guess we'll call it future vision of what could be built with InterSystems technology to create a FHIR ecosystem, still assuming that we need the FHIR profiles and semantic interoperability.
My name is Mark McKinney. I'm the CEO of HXNY. We're an HIE in upstate New York. We've been on InterSystems HealthShare for about 12 to 15 years. I'm not exactly sure the number at this point, but certainly a very long time. We've been in business for about 24 years, and in that time, pretty much every healthcare organization in our region is connected to us and exchanging data with us and getting access to it. What I wanted to talk with you today about is a Smart on FHIR application that we've built to really make it a lot easier to push information into and out of the provider workflows. Go to the next one. So we call our application Patient Record Snapshot. What it is, obviously, Smart on FHIR actually brings together two technologies. Brings together the SMART technology, which stands for Substitutable Medical Applications Reusable Technology, I think. Essentially, it's a way to open an iframe inside another application. And then we use FHIR as the way to communicate and share the data between those two applications. And so you can use that. In our case, we use that to put a single application both into our InterSystems provider portal through HealthShare, as well as we can embed it into those EHRs you see listed on the right side of the slide, and we've got about another 5 or 6 that we're working on right now. It gives us single sign-on, it gives us patient context, so the provider can stay right in their workflow. It enables us also to bring in tools and information that's not native to the workflow or the application that they're working within. And most importantly for us, it gives us a way to ensure that we have a consistent user experience across any of the platforms that they're accessing. And so, and most importantly, like I said, it gives us the opportunity to stay inside that workflow. So this is what the application looks like. As you can see, this is right in the HealthShare application. So we've embedded it. It becomes just the first page, page tab up on the left corner of the HealthShare application. All the rest of the tabs are the standard application tabs that would be there in the InterSystems provider portal. But this thing gives us the ability to do really five 5 key things. One, it gives us the ability to present our data in an easy, seamless way. It allows for search and other components and technology in ways that we want to control the way the user can use that, to download data, to view data, and to do a variety of other tasks. We also can embed other applications inside our own application. So we use this as a way, for example, to take applications that the New York State Department of Health has developed, and we can embed those directly into our application. So a user who has credentials to a New York State application to look up opioid information that normally would have to leave the workflow in order to do it, can do it directly through this application seamlessly and with single sign-on. In addition, it gives us the ability to look at patient insights. And this is the ability for us to take the data that we're collecting using FHIR, and it gives us a way to then evaluate that data and make inferences about what's happening with that patient and make that available to them. When we use the FHIR technology, the Smart on FHIR technology, we're using FHIR both to go into the EHR to retrieve data. If the EHR will let us, a lot of EHRs will not, we can use it to push data into the EHR. We also can use that technology to go back into HL7 and retrieve data out of it. We also can use other APIs as well as ways to bring that data forward into the application. In addition to those first 3 components, the other 2 components really are linked, and they're around the idea of around health-related social needs, and we're able to do really 2 things with that. One is we're able to support the ability of a provider to create social care screenings for patients and to make social care referrals. And that's where I'll focus for next second or two. If you look here on the left, we have this capability where users can select a screening tool, and we can have the ability using metadata to load as many different screening tools as users would like. We have then taken and mapped all that semantically underneath back into HL7. And then we use FHIR as a way to collect that data discretely as resources, and we can then allow the provider either through interviews to collect that data and enter it directly into our application, which then gets back into HL7 and is available to all providers using the application, or it allows the provider to send text messages and emails to patients where they can collect this information offline, and then that gets back into the system the same way. The other thing then, if that screening tool identifies a need, so a patient has food insecurity or needs transportation and assistance getting to medical visits, that would then create a need for a provider to make a referral. And so we have created a system that enables a provider to, with a couple of clicks, make a referral to a social care system, and using that, they can kind of complete the loop. So when we're doing the screenings, the provider will validate some information. If we have a cell phone number, email address, we'll make that available. If we don't, the provider can enter that information. They can hit send, and then the provider receives an email or a text message. They validate through two-factor authentication, some information. They complete that screening. Once that screening is completed, the provider is notified. That data is then sent back into the system. Our insights component then evaluates that and recommends referrals that need to be made. And then we also then will make that data available to all the providers in the system. And you can see this is what the data looks like. It's all discrete data. It's all been mapped back to the problem lists. It is then also information that is discrete, and then we can push that out as JSON objects in FHIR. When we're making referrals, we give the provider 2 options. What's labeled option 2 here is an option in which they can choose which organization they want to make a referral to. They select the YMCA, they click refer, add a couple pieces of information, and they click send. The reality is almost everybody does option 1 about 99% of the time, and that is to actually just say, I want to make a referral, tell them what type of referral they want to make, and then they send that to another organization as a JSON object using the Gravity Project standards, and then they take that information, map that up against the patient needs and the provider resources, and they make the referral to the appropriate organization. That information then ends back up in our system, and the providers can view it. Here is the human-readable version of what that data looks like when it goes off to those folks. But what this does is it gives us the opportunity to bring together health-related social needs and clinical information all in one place, and to do it all within the provider workflow. And it's really the ability to use FHIR to be able to carry that information both forward to the EHR and backward to our systems that makes that possible. So that's what I wanted to show you today. Thank you.
Yeah, I saw the full one-on-one demonstration of this at HIMSS, and it's very impressive and has a lot of potential, I think, for other. I see this as sort of a prototype of what can be done. So I had a question. What's the trajectory of the EHRs providing access and bulk FHIR or any other access?
So what we're finding with the EHRs is they're getting a lot better with being able to support FHIR and the ability to retrieve data. We haven't worked that much with the bulk FHIR components because obviously they're still forthcoming. But what we're finding is that a lot of the EHRs are very restrictive on the ability to put data into the EHR. So if you're looking at data, right, and you're a provider, what do you want to do if you see a lab test you don't have? You want to download it and put it in your EHR, right? And so, but the problem generally has been that a lot of CIOs are very hesitant to do that because they're concerned that if they do that, they're opening themselves up to security concerns, right? I could put bad data into my EHR. Somebody could have coded a diagnosis and put it into the procedure section because it was incorrect or something else. So they're very concerned about the ability, even though it's very easy for us to push that data as FHIR directly into the EHR, to allow that to occur. So a lot of what's happening today is actually downloads of PDFs. So while they're much better at letting us reach in and get the data out by FHIR, their ability to then consume that FHIR back in is not really quite as mature yet.
The question?
Sure.
That example you gave, sending out a social questionnaire, when that data comes back, where do you persist it? Do you persist it in your own data?
Yeah, we persist it in HL7 FHIR, and so and then we'll send it out if somebody wants it as well.
Do you create your own sort of EHR?
No, we're just using the standard SDA data model of HL7 FHIR to store the data right now.
Well, thank you.
All right, thank you.
So we have an ask. The QR code that you see on the screen is a short survey. We're working on developing a tutorial type application for people to learn about FHIR and particularly around the FHIR questionnaire resource, but other FHIR data. And we have a few different use cases, and we're trying to settle on, or at least prioritize them, and would like your input on what you think of the use cases, or do you think there's another use case that would be a killer app that would be better than these use cases? Not a killer app, but a killer use case, I guess. So if you have time, there's also the QR code outside on an easel if you can't get it off the screen here. And the last thing I wanted to do was make you aware of some of the FHIR-related content in the rest of Global Summit. It's all in your cVent app, but to save you having to scroll through, we've listed these sessions that range through a number of different uses of FHIR, clinical research, bulk FHIR, and it goes on. alerts, notifications with our new healthcare action engine, a rules engine that you can build without coding, that's FHIR-based, FHIR validation, building a FHIR facade, as I described, is a FHIR API that doesn't have FHIR on the back end. There's also several of these use cases in the demos and drinks, new format for a global summit. Not that there were never any drinks, but we didn't have the demos at the same time. These are sessions in the Tech Exchange related to FHIR, the FHIR SQL Builder, which is an awesome creation of Pat Jamison's. And certainly for the rest of the Global Summit, I'm happy to talk to anybody. I know Pat would be happy to talk to anybody, and I'm glad, thank you for spending the afternoon with us, and great to have you here.